Well, I'll send my apologies in advance. I am just popping in as a quick response to your invitation, but I'm afraid I have to sign off pretty quickly. But just wanted to say hi and wish everybody the best and all those kinds of things. How are you, Steve?
Ken, it's great to see you. We have you at the top of the agenda. Just want to formally acknowledge you and before you step off. So if you can just give us 1 second, we'll call the meeting to order and start with that. It's great to see you though.
You too, you too.
Commissioner Danovich, we do have a quorum.
Okay, great. Great, thank you. Thank you, Kai. And pull up my agenda. All right, good afternoon, everyone. Thank you for joining us for today's teleconference meeting of the Commission's Research and Evaluation Committee. I'm going to go ahead and call the meeting to order. Kai, can you please take the roll?
Yes. Ricky Addis.
I'm here.
Sergio Aguilar-Gaxiola. He will be joining us at 2 p.m. Robert Brooke.
Here.
Eleanor Castillo-Sumi. Jonathan Friedman. Sharon Ishikawa.
Here.
Bridget Leary.
Here.
Gustavo Lara.
Here.
April Ludwig.
Here.
Linda Lyons-Newman.
Here.
Leisha Ostro. Mari Radzik.
Here.
Ruth Shin. Lonnie Snowden. Catherine Watkins.
Here.
Chair Danovich.
Here.
Vice Chair Carnevale.
Here.
Chair Danovich, we do have a quorum.
Great, thank you. All right, some general housekeeping as we begin. Some of you may not be familiar with the procedures for making public comment, so I just want to briefly explain or remind you of the process. If you want to make a comment on an agenda item, and here before you see the agenda, please wait until that agenda item starts. You may request to make a public comment by clicking the raised hand icon on your computer on the Zoom interface of the app, or if you're calling in by pushing *9. You'll be placed in a queue to comment on that agenda item. When it's your turn to comment, the moderator is going to unmute your line and announce your name or the last 3 digits of your telephone number if you're calling in. Once you're unmuted, we'll be able to hear you. We will do our best to take comments in the order that they're received. Please be prepared to complete your comments within 2 minutes or less, depending on time constraints. When we've reached the end of your time, our staff will let you know, but we'll let you finish your thoughts. This is easier when we can all see the clock in person. It's much harder in Zoom, so apologies in advance. We never want to cut you off, but we do need to maintain our time limits to get through our agenda and make sure we hear from everybody that we can. We appreciate your understanding of this process. We have committee members and folks listening in on the phone. Please make sure to introduce yourself before speaking and to speak directly into the microphone at all times. So with that, let's review our meeting purpose and agenda. Since we last met in September, a lot's happened. We had the holidays, we had the new year, we had another surge of the pandemic that is hopefully waning. It feels like between every set of months is like a decade in terms of all the things that happen, for better and for worse. One of the things that's on the worst side is that Ken Barrick, our vice chair, departed from the commission. And so he's no longer going to be serving in his role as vice chair. We did invite Ken to be here today so that we could have a chance to thank him in this format and to honor him for his service to the commission and to the committee, and to wish him well with his many new and continued endeavors. Ken has fortunately recently been appointed to serve on the Children and Youth Subcommittee of the Commission. So we may be hearing from Ken in the future in the context of that subcommittee's work. Ken, on a personal note, it really has been an honor and a privilege to serve with you on the commission and on this committee in particular, to work with you more deeply. I'm going to really miss your intelligent pragmatism and your sharp wit, your open mind, your deep passion for touching people and improving their lives, and with a particular focus and commitment to youth. And I'm going to miss your good sense of humor and your heartful laugh. Let me just invite you to say a few words if you'd like.
Thanks so much. You know, I have loved serving on the commission, and I particularly loved serving with you. I really, you have such a gracious way of both bringing people in and engaging them, and also keeping us on track, which I have personally really appreciated when on those moments when I've been tempted to maybe be a bit more expansive than was helpful in the moment. I think this committee is remarkable. Its membership is remarkable, and I think we crafted it to be folks that really bring something to the table. And I think what we're doing together is remarkable. And I also in making the transition and working on the task force for the behavioral health, am seeing a time of amazing opportunity with this administration's vision for behavioral health, and the potential for the combination of what we're doing with OAC and what the administration is doing more broadly. So I couldn't be more excited to see what's next and to watch and hopefully help craft it. And I'm very grateful, particularly to you, Ty, but Steve, to you, to the members of the committee, many of you who I've known for many, many years, for this incredible work. So thanks for giving me the chance, and thanks for giving me a minute to join you today.
Well, thank you, Ken, and we are, and I'm not going to let you out of our orbit. So look forward to being in touch.
Terrific.
Okay. Well, I'm also pleased to announce the appointment by the commission chair, Chair Madrigal-Wise, of Commissioner Steve Carnevale as the new vice chair of the Committee on Research and Evaluation. Steve is a very successful businessman who has devoted a significant portion of his life towards helping young people with mental health challenges. He is the founding chair of the advisory board for the UCSF Dyslexia Center. He has led work with nonprofits, schools, corporations, and foundations around improving literacy rates, particularly among disadvantaged children. And he brings a no-nonsense approach to getting things done. Also a deep intelligence, curiosity, openness, and commitment to this work. So welcome, Steve, to this committee. And I look forward to, and I know we all look forward to working with you, and would invite you to say a couple of words if you are moved to.
Thanks, Itai. I am a poor substitute for Ken, and I am missing him already. But I am very excited by what you and he and others have built here. The research, for me, is the most hopeful part of the commission, because it gives us an opportunity to make a better future for everybody. And the evaluation work helps the commission to better evaluate and assess our program choices. So to me, this is a really, really important committee, and I'm excited to be part of it.
Right. Well, look forward to continued work with you, Steve, and now in this capacity. And finally, I want to announce that Dr. Dante Early, our previous chief of the Research and Evaluation Division, was named president and CEO of United Way California Capital Region last November. Some of you may have heard that. So she has transitioned off the commission and off of her role, ably supporting the work of this division. We are developing a plan, and we'll soon be posting a position in order to hire a replacement for her. And this is where I would call on all of you, our committee members and our members of the public. I would appreciate your help and support in recruiting through your professional networks and contacts. We want to identify the most capable candidate that we can for this incredibly important and impactful role as chief of the Research and Evaluation Division. It's a huge part, incredibly important role for the commission on the whole and for the Act. So we will keep you updated on this position as it becomes formally announced and posted. But please do go through your virtual Rolodexes and your minds and think about people that might be a good fit for this. We would really appreciate you bringing them forward to us and making them aware of the opportunity. Now for today's meeting, we're going to continue with our focus on children and youth. Our goals for today are first to present the Commission's research agenda for 2022. I would ask you to look at the meeting packet for the Research and Evaluation Division's strategic plan, but we will be presenting a summary of that. We are also going to be providing an update on the Triage Summative Evaluation Plan. If you'll recall, at our last meeting in September, the committee received a presentation on a draft plan, a plan to evaluate outcomes for the Triage grant program. Today, we're going to be reporting back to you on our progress implementing that plan, which includes responding to recommendations that you provided in September when we met. Finally, today, we're also going to be receiving a presentation from an organization called Children's Now. Children's Now produced a recent report, which is in your packet, that catalogs the different types of behavioral health measures that are available for children and for youth and collected in California. And from this presentation, the committee is going to consider and discuss measures that the commission might be able to track and report on. We have a committee member, Dr. Catherine Kate Watkins, and a member of the public, Dr. Lynn Toole, who are going to be leading this discussion. So we have a lot to cover today, hopefully a lot that we'll accomplish. And so let's begin with our first agenda item. We're just a couple minutes behind, but I think we can do it quickly, which is approval of our meeting minutes, which are located in your meeting packet. Do any members have any questions or comments about the meeting minutes? Seeing none, do any members of the, Mari, were you signaling?
I was signaling no, I do not.
Oh, okay, all right.
Thanks for being so on alert. I can't see anybody, so it's
You happen to
amazing.
be, I have only a few, faces that I could see on my screen, so I apologize to everybody else whose signals I can't see. But is there anybody in the public that wants to comment? And I would remind you to use your raised hand feature. That I think will elevate you. And Kai and Sharon, if I miss anybody, hopefully you'll bring my attention to it. Okay, well, seeing none, is there a motion to approve the meeting minutes?
This is Gustavo. I'll motion to approve the minutes.
Okay, thank you. Is there a second?
This is Sharon Ishikawa, I second.
All right, thank you. So Kai, please call the vote. Oh, we can't hear you.
Ricky Addis,
Yes.
Sergio Aguilar Gaxiola,
He's going to be joining the meeting at 2.
Robert Brooke,
Yes. Eleanor Castillo-Sumi, Jonathan Friedman, Sharon Ishikawa,
Yes.
Bridget Leary,
Yes.
Gustavo Loera,
Yes.
April Ludwig,
Yes.
Belinda Lyons Newman,
Yes.
Leisha Ostro, Mari Radzik,
Yes.
Ruth Shim, Lonnie Snowden, Catherine Watkins,
Yes.
Chair Danovich,
Yes.
Vice Chair Carnavale.
I'll abstain.
The motion passes.
Great, thank you. Okay, with that, we'll move on to agenda item number 2. For this next agenda item, Dr. Toby Ewing, who is the Executive Director of the Commission, will be discussing the Research and Evaluation Division's strategic portfolio and current activities, including legislatively mandated evaluations of Triage Crisis Service Grant Programs, Mental Health Student Services Act grant programs, and FSPs. I will turn the presentation over to Toby. Toby, please feel free to take over.
Thank you very much. And just to update you, so the position for the Chief of Research or our Research Director is on the Commission's website and posted.
Oh, great.
Yeah, and but if you have questions, please let any of our staff know, and we'll help you sort of navigate that process. We recognize that if you're already in state service, it's a pretty straightforward process. If you're not in state service, it can be a rather cumbersome process. And so we're happy to be a guide to make sure that that process does not become a barrier to excellent candidates learning about the opportunity and engaging with us. So thank you, Mr. Chair. So I'm going to really cover 3 things, and I'm filling in for Dr. Sela, who's out at the moment, and so I apologize in advance that as I try to kind of step into Brian's not just his sizable shoes, but his sizable brain and all of the intellect that he brings to this work. So I apologize if I'm not as fluid in everything that's happening as I try to step into the role. Really want to just provide a broad overview of kind of the role of research and evaluation in the Commission's broader portfolio. In other words, what are we trying to get done here? To give you a pretty high-level overview of what's in our portfolio at the moment that is tied to the goals that we have, and then talk a little bit about moving forward and some context, particularly around the opportunity to establish statewide goals and measures. And it's important, I think, to understand that where the Commission has a very clear vision, at times, sometimes it's more clear than others, but even when we do have a clear vision, we really work within the constraints of our budget and our statutory authority. And sometimes, those structures complicate our efforts to move forward in some of this work. And so I'll provide some reference on that. In terms of our strategic goals related to research and evaluation, I think of that as really why we do this work. And we're really trying to achieve a number of objectives. One is creating greater awareness about what's happening in the mental health system that we have today. Some of that is helping people understand how our system's designed, understand what's working and what's not working, and really recognize opportunities to enhance access to care, the quality of care that people receive, and the outcomes that we achieve through those strategies. There's a lot of tension in that space, particularly around what we might refer to as the jurisdiction of the Commission. And I use the word tension very intentionally. There are lots of different perspectives and opinions of what the Commission's role is. At its core, though, the Commission is an independent body and has tremendous discretion to set its agenda and to move in the direction of that agenda in the context of the resources that we have, staffing, funding, and so forth. So the commission has been pursuing a number of initiatives to try to address just some fundamentals around the mental health system, trying to understand what the system looks like. And as I mentioned, highlight opportunities for improvement and scenarios where we're actually doing a pretty good job. We're also trying to marshal information, data, metrics, and information around policies and practices to help people understand the specific aspects of our system, like access to early psychosis care, or challenges that we see in the state of California with regard to suicide. We're making a huge investment in school mental health, in youth drop-in services. We've done a lot of work using data to better understand opportunities for diversion for those people who are justice involved. And so understanding the nature of justice involvement for people with mental health needs is part of our work. So it is both this broad overview of the system we have, and it's often a drill down analysis of what's happening in a given space. We also do some work in trying to understand incentives, returns on investment. It's much more difficult to do. Of course, the goal is often really understanding whether or not the services that are available are resulting in improved outcomes in the lives of individuals, families, and in the lives of communities broadly defined. And within all of that work, there's a heavy emphasis on understanding disparities, disparate outcomes, and how they impact particular communities in California, particularly communities of color, communities that don't speak English, that might be immigrants and refugees to the United States, or recent arrivals to California, differences in terms of socioeconomic status, gender identity and sexual orientation, age, certainly. And then, the third piece really is often helping the legislature and the governor make informed decisions about programmatic and policy investments that they might be making. And so very broadly, this work, the commission's work, is really designed to inform decision-making at various levels, at the county level, at the state level, in policy, in programming, in financing. And all of that is because the commission was formed for two fundamental reasons. One is to promote a higher level of understanding and trust in the public around what's happening in our mental health system. And two is to really shape understanding and knowledge and political capital to draw attention to some of the challenges that we have in our mental health system so that we can drive towards improvements in those areas of investigation and inquiry. So, broad overview, why we do this work. Our current portfolio is quite broad, and it ranges from those things that we're required to do under law, mandates, specific mandates, to things that the commission has directed staff to do, not required under the law. It's discretionary on the part of the commission, but the commission has elevated as a priority. And then there are opportunities and activities that we're pursuing that are more foundational, they either inform something that the commission has directed us to do, or they lay a foundation to support future work that we think is important. So among mandates, we're required to improve understanding and issue a report on the Mental Health Student Services Act investments that we're making, which is all about supporting collaborative partnerships between schools and county behavioral health departments throughout the state. We're required to do a report on funding we give away to support California's continuum of care under a program called Triage, also known as SB 82. More recently, we've been directed to issue a report on how our full service partnerships are operating. We do a lot of work on, the commission's required to do work to review and approve county innovation plans. And as part of that, we're trying to put together better fiscal accounting of funds that counties have for innovation. And part of that is we often find ourselves in a crunch as multiple counties will give the commission innovation proposals to review and approve before a statutory deadline of June 30th. And we're trying to do a better analysis of innovation funding so that we can help counties develop a longer timeline to avoid that crunch. So there's an example of, it's not a mandatory activity, but it will support our ability to actually pursue a mandated activity, which is reviewing and improving county innovation plans. So part of this conversation is trying to get a broader handle on what are we trying to achieve, or having clear goals for different programs. As you have talked about in the past, clear metrics. How do we know if we're making progress? As new commissioners come on board, and so I remember the first time I sat down with Commissioner Steve Carnevale, he'll ask very intelligent questions. What are your goals? What are your metrics? How do you know you're making progress? And in the public sector writ large, this is really difficult to do for lots of reasons. The biggest reasons have to do with how we design and develop our data systems, which at their origins were very rarely designed to actually support inquiries around how people are doing. They were typically designed to track spending and to support reimbursements. And so as a result, most of the data that we have is not conducive to the level of detail that people are looking for in some of this work. So as a result, we try to work with proxies. We try to come up with different ways that we can actually use existing information or supplement data with qualitative strategies where we can do a great job describing what is happening in this space, because often the challenges we have, we know the outcomes aren't great. You don't have to go very far out of your home or your business to see the kinds of impacts that we're having in California in terms of unmet mental health needs. But it is very difficult to actually measure the return of a particular investment in a program or a treatment or an outreach strategy. And so, this work is hard because we're trying to meet those very clear and defined objectives that policymakers and the public have in their mind, but get really messy when we begin to try to take actual information and translate that into actionable knowledge in a traditional evaluation or business reporting sense. So that's a very broad overview of kind of who we are, what we do, and why. A very brief discussion of some of our portfolio, not all of it, but I thought it'd be helpful to point out that we have some mandatory work. We have some work that is commission directed, and therefore it's mandatory to staff, if not legislatively mandatory. We do have some discretionary work that is designed to support our broader goals. And then we do have activities that are designed to provide broad information as part of our effort to create trust and understanding. So moving forward, and what we've really struggled with, and I think what the kind of the immediate opportunity is how can we begin to create a core set of indicators that will support conversations around the outcomes we're achieving for children and youth with mental health needs. Itai, anything that I left out or anything else you want me to cover? Was that too fast, too slow?
Thank you, Toby, for that, and thank you for stepping in for Brian. Let me turn that question over to the committee first, just to see what questions folks have. Questions or comments?
Silence either means you knocked it out of the park or nobody came to the game.
Toby, this is Gustav. I have a question. You mentioned, I think you mentioned qualitative, either qualitative approach or qualitative, I guess looking at data from a qualitative perspective. And I was glad to hear that. Can you expand a little bit on that? Because it seems like a lot of the measures that I'm looking at are mostly quantitative. Just kind of curious in terms of the qualitative part of it.
So thank you, Gustavo. I appreciate that. I had a conversation about a month ago with legislative staff, and invariably, when the commission is funded, as when most departments are funded, the statute will often say, and do an evaluation, and it will leave it at that. And 20 plus years ago, I led an initiative with legislative staff about what did they really mean when they said that. And that initiative was led because of a long history, and I'd say it continues today, that policy staff, which are not researchers or evaluators, have this sort of generic sense of, we want to know if this investment we made or this policy we wrote works. And so they'll say, tell us if it works, and never really get into what that means. Like what decisions are you trying to inform? What information are you trying to get at? Do you want to know return on investment? Do you want to know if people have, if their healthcare is improved, the lines at the DMV are shorter? What is that? And rarely is that articulated in the direction that is included in the budget or in the legislation. So, so part of this is just trying to create clarity of what decisions are we trying to influence? And then how can we think about information analysis, reporting, communication to support that decision making? So on the qualitative side, it's if we're thinking about something along the lines of, do people have access to care? And so one way we might answer that is looking at penetration rates of those who are eligible, how many are actually receiving services? But it also could just be, are the absolute numbers increasing relative to overall population, right? The penetration rate might have stayed the same as the eligibility numbers changed, but the total people served went up or down. But a corollary to that might be, what was their experience, right? Sometimes we think about difficulties people have accessing care is because care is not long waiting lists. But sometimes people have difficulty accessing care because they don't know that care is available or that they need it or where to get it. And so there's lots of ways that we can listen better to the customer in that instance. And in some cases, for the commission, the customer is the county, right? So for example, we recently issued an RFP for a grant program on school mental health, and we had 20 counties that didn't even apply, despite tremendous need in the community level. They didn't apply. So we spent a bunch of time asking strategic questions of why they didn't apply. And so, we do those kinds of, we use those kinds of strategies, which was not a formal qualitative research project, but it was this sort of intense focused effort to understand why we were not getting the response we were looking for. And the outcome of that, those 20 counties, 17 ended up applying because we removed tremendous barriers that we didn't realize were there because we hadn't asked. There's a lot more to that, but that's a sort of a sense. I hope that's helpful.
No, thank you. And I think I was exactly when we look at quantitative data is one thing, and there's a lot of limitations we look at quantitative data, but to also capture the stories, as you mentioned, Toby, the experiences of people, I think could strengthen the quantitative data. So I think that's again, thank you for expanding on that.
Yeah, I would add, Solano County saw a 300% increase in access to care for one of the populations that had the lowest penetration rates because they talked to the community, did a lot of interviews about how they described services. The words they used in non-English speaking communities actually were getting in the way. And so just simply by spending a lot of time listening, they were able to make some changes in the way they created paths to services. And again, 300% increase in access in the numbers that were from those populations that were knocking on their door for services.
Thank you. I see Bob Brook has a hand up, and would just encourage any other committee members or members of the public to put your hand up. That will let me know how much interest we have in responding to this in the remaining 10 minutes that we have on this agenda item.
Hi, I enjoyed the presentation. I was, interested in the opening, which you indicated that you had little budget and a lot of statutory limitations on what you can do. And then you went on to describe an extraordinary, extensive, elaborate evaluation plan, which the two didn't seem to match with me. So at some point, could you enumerate precisely to the governor or whoever you enumerate, what are the statutory and budget limitations that would prevent you from achieving the second part of your talk? Or is that off the table? Because that's how you began. I'm just Now, the second thing is I understand all the things you said are very important, but I'm really concerned about focus. And I would love to have an answer to the question of what do you think will be actionable items by whom, based on what you have done, not what other people have done, but what this commission and the evaluation will change something. And who would have to be involved in changing that, so we make sure that we're not going to surprise them with what we say. And at what level are the changes going to occur? Are they at the community level? Are they at the patient level, the governor level, or where are the changes going to occur? And it would be nice to have that precisely laid out. It's hard for me to believe that all the things that you laid out could be done by this commission, given the beginning, the budget and statutory limitations. I don't expect an answer right now, but it would be nice to know, nice to have one or two actionable things that we've done that somebody will do something with, that will make a difference that's meaningful and justify, all the hard work that you guys are doing.
Thank you, Dr. Brooke. Let me just, I'd love to just sit down with you and kind of walk you through some of that. I would say very broadly, so for example, there is a mismatch between the opportunity and the resources. And that's just sort of life, right? That's just the reality that we live in terms of limited budgets and unlimited hopes and dreams.
Well, just let me stop, and then I don't want you to respond.
No, and I was gonna get to the focus really fast. I was gonna give you two examples.
Let me just say one thing. That would be really nice for the governor to know now. He has so much money that he doesn't know what to do with it. It would be really nice if the governor, if there was an op-ed piece, if you really could write that up now, that might do more to improve the mental health of children than other things. So I don't know who knows that. And it shouldn't be just me. It should be all the committee, all the people that are looking at you at this moment should actually understand that in enough detail so they can be your advocates in trying to do something in this area. I'm just, we want to be on your side.
Yeah, no, I appreciate that. But let me give you an example where we have used data in a compelling manner that was a game changer. So, one of the first things we did when we sort of tried, kind of stood up this opportunity was to provide clarity around Mental Health Services Act funding. Many questions. This commission had a fiscal oversight advisory committee that met 4 times a year. Lynn Thole, if she's here, was on that back in the day. And we stepped back and said, what are that committee would meet 4 times a year, and we would talk about revenue projections and what we thought was happening. And what we did was to sort of, settle all of those in the weeds kinds of questions that were really important to everybody, but impossible to answer. Are children getting more funding today than yesterday? It was very hard to answer those questions in a systematic manner. So we said, what are the top level issues that if we could answer them, it would actually be instructive in your work? And we had public members and providers and county leaders in the room, and they said, we want to know how much money is there. We want to know that over time. We want to know what statewide and for counties. We want to know what's being spent, and we want to know how much money is left in the bank. So we worked with messy data that was incomplete and often not timely, and we put it all online. And the process of doing that, creating a what we call our fiscal transparency tool, actually resulted in the data getting better. And it actually resulted in significant behavior change. There's a law that says counties have 3 years, in some cases 5 years, to spend these dollars. And if they don't spend them, they have to give the money back. And the reality was the money wasn't being spent and they weren't giving it back. It was just sitting there. There was over $350 million that had been sitting in county coffers for more than 3 years. That has stopped. And we're seeing greater attention on understanding financing and revenues. And we get calls every week asking us to update that information. So I think, we are in a position, if as you say, we're very focused if we can identify an opportunity that is achievable, not every wish that everybody has, and garner the right kind of data and put it together in a package that is easily to access, because that information had been available publicly for 20 years, but that doesn't mean that it was easy to access. And if we do that in a strategic manner, it actually can shape behavior. And that got the governor's attention. You know, the unfortunate news was some people lost their jobs because of prior behavior. And the fortunate news is we're seeing much more attention on the adequacy of resources relative to the need. I think part of this opportunity is if we could do that on some key metrics, what would those metrics be? And how could we use that conversation to shape understanding and decision-making? But Dr. Brooke, I really appreciate your guidance of sort of expanding understanding of the mismatch between the essential nature of information and the state of investment that we're making today.
Okay, thank you. I think we have time for one more question for a committee member. And apologies, members of the public, I misspoke. We're going to have a period of public comment, I think at 3:30. So Martin, I saw that you had a comment, and I would just ask you to please reserve it for that period. Appreciate that. Thank you. Okay, if there aren't any other comments from committee members, I'll move us forward. I do think, Toby, thank you for that, and thank you, Bob, for the for the comments on that. This is our prior discussion about these challenges have contributed ultimately to our decision to focus on school-age youth, and specifically on initiatives that have arisen through the Act and where the Commission has mandated requirements to evaluate, to focus on conducting effective and impactful evaluations. And Toby, what I hear is the feedback from Bob, which is not new and others have expressed as well, is that in areas where there are critical evaluations that we would like to conduct but cannot, that we need to elevate and create awareness around the opportunity and the gap in order to take advantage of the windows of opportunity that do exist to make resources available to do the evaluations that we need and to be able to do the work that we need. The next item on the agenda is going to be an update on the Commission's Triage Summative Evaluation Plan. If you'll recall, the Commission is conducting an evaluation of Triage grant programs. This past September, staff presented the evaluation plan to this committee and received feedback. At that time, the committee, endorsed moving forward with the plan, taking and gave a number of suggestions, including issues around evaluation design, data quality, equity. The goal of this presentation is to report back on how your feedback was incorporated into the Triage Summative Evaluation Plan. And to do that, I want to welcome Dr. Callie Clark, who is a senior research data analyst at the Commission and the lead for the Triage Summative Evaluation. Callie joined the Commission last November. Formerly, she was senior research associate at Temple University, where she conducted evaluations of interventions and policies aimed at reducing basic needs and security, such as access to food, housing, and mental health services for college students. So welcome, Callie. We'll turn this over to you.
Thank you so much. I first want to genuinely thank everyone for allowing the opportunity to provide an update on the Triage Summative Evaluation. This is going to be a relatively short update, but I do just want to make sure everyone knows what we've done since September, because it's been a little bit of time. Before we get started, I first just want to talk about how we approach research at the Commission, and particularly how we are approaching research with this evaluation. So we approach research with a research practice growth model. And what that means is that we don't conduct research on individuals or on populations. We conduct research with individuals, and we hope to provide tools to help those individuals and service providers grow. In this case, we're talking about working very closely with our county grantees and using platforms like this to get feedback from a number of stakeholders so that we can create a conversation, an iterative conversation that builds and grows and is a longitudinal growth model. So this evaluation plan and the changes that have been incorporated to it are a perfect example of how we use feedback from those around us to make our evaluation and our research stronger. So it is genuinely a partnership, and I want to thank everyone who took time to provide feedback on the evaluation plan previously. It was indeed helpful in moving that plan forward and making it stronger. Today, we're going to talk about just a few things. One, I will update everyone on the feedback that we got from committee members and the public. And then I will also update on the data that we've received so far and the status of that data and the percentage of grantees that are reporting. We can go to the next one. Okay, so in reviewing the feedback from the previous meeting, one thing that came to light were there were some 4 major themes in the feedback, and they were around primarily the evaluation design, how we are approaching questions, data quality and the source of those data. So what are we using to answer those questions? Equity around who is using services, receiving services, and equitable access to services, and outcomes. And then also these larger questions around workforce capacity and whether or not the system is actually working and functioning the way that we intend. Next slide. Okay, so I'm going to go through each of these just briefly. We were able to address and incorporate feedback around looking at differences across counties. So it is a methodological challenge when you have counties that are implementing different types of programs with different populations. However, the methodology that we've chosen, given that feedback, should address this very well. We are using multi-level modeling in order to account for some of those between county differences. We also heard the feedback and are planning to compare clients within the same county when at all possible. And then lastly, we would like to discuss the timing and acknowledge the timing of the evaluation as happening after the start of implementation. So we do want to acknowledge that and the limitations that that puts forward. Now, there are some aspects that we aren't able to incorporate at this time, but we are looking at how they might be incorporated in the future. And one of those is about the very important aspect of quality of life. We really thought about how we could find a measure that would be easily implemented in the field. And we looked at options. We did not find one that fits for us right now that we think would work. But then there's also this larger question of this is an evaluation. And in order to do that, we would need to compare those same quality of life measures for people who don't receive triage services. And we are not able to administer such a survey to individuals who don't get triage service. So right now, we aren't able to address the quality of life in this evaluation. However, it is on our radar and we will continue to look at it wherever possible. Next one. Okay, data quality and source. Okay, so there was a few very important comments brought up. One of them about what's going to happen with individuals who aren't able to report a social security number at their intake, and what happens to those individuals? How does that impact the entire evaluation? We are able to match for a number of our state databases. We are able to match without social security number using a number of other characteristics for individuals. However, we do have some limitations with that, and that we will have to acknowledge how our samples look different and really pay attention to if we see that there's particular subgroups of people who might be negatively impacted in our estimates. That's something that will be an ongoing process. However, we are confident that for the majority of our databases, we will be able to do matches, even if we don't have a social security number. We are, and one of the most, I think, important contributions of this work is looking at categorizing and summarizing triage services. We receive feedback on that, and that is absolutely a priority for us. That is part of the data and the feedback that we want to provide immediately, as soon as we can, to grantees, to service providers, to policymakers. We really want people to know, how does usage of service look across the state? How different is it? And allow counties to seek out those learning communities with counties that are doing similar things, but also to seek out opportunities where they can find opportunities for improvement or to fill a gap in services that might come through the data. So we do take that very seriously, and we're excited to share those data as soon as we are working through them. We will be able to examine differences in outcomes by service type, and we are working to standardize the variables and outcomes so we can make a statewide evaluation of triage services. We are not right now able to incorporate California Reducing Disparities Project core measures or CANS data. We really would love to, but unfortunately we don't have those data. That's something that we'll have to keep on the radar for future evaluations and to consider how we can work to get those data if at all possible. Another thing we're not able to address right now is dosage of services. Right now, and that would, a question around dosage of services would be maybe what's the ideal number of a certain given service type to have the most ideal outcome. It would be something that might be able to be asked in the future once we have a strong understanding of this first evaluation and what the impacts of triage have been statewide and within counties. Next. Okay.
Can I ask one thing? I should have mentioned this at the outset. We may have folks on this call for whom we haven't previously discussed what triage is. So could you just give a one-liner of what triage is and what we're trying to achieve with this evaluation?
Sure. So in Senate Bills 82 and 833, there are funds allocated to increase personnel for grantees, particularly targeted around crisis services for individuals experiencing unmet mental health needs. And that could look like a wide variety of things. So grantees, in order to make sure that grantees, which are typically counties, are able to meet the needs of their individuals in their region and in their locale, there's great flexibility allowed for those grantees to develop the types of programs and to target different populations that they feel would benefit the most from this infusion of additional funds. Now, it is our job at the commission to do a statewide assessment of what that looks like, what the potential impacts could be. So we're in the second round of triage grant funding. And I'll go over in a little bit the number of grantees we have and what those grantees look like across the state. But that's a general idea. So this is a statewide evaluation of what that infusion of additional funds, the impacts that those may have had in reducing disparities, but also increasing access, along with improving longitudinal outcomes for individuals who receive those services.
Great. And given the focus on school-age youth, can you speak to the category of grants that focused on schools?
Sure. So we have 3 different types of grants. We have grants that focus on adults and transition age youth. We have grants that are specifically targeted towards children, but are not necessarily embedded within schools, although they can be. And then we have a very particular type of grantee, which is a school-county collaboration. And we'll go over in just a little bit what the numbers for those look like. But in general, our grants for adults and transition age youth and our grants for children make up the bulk of our recipients. We have 4 school-county collaborations currently.
Thank you.
Of course. So we did receive some questions regarding equity. So, and we take these very seriously, and we were able to incorporate a lot of what people were asking for. One is people wanted to make sure that we were going to look at differential usage and impacts for people of color, which we absolutely will. That's definitely a priority. But then there were also concerns about how are we going to standardize very important demographic variables across counties? And this is something that we've worked with the grantees to do, and we are able to standardize these variables so that we can draw comparisons across counties. Right now, one thing we're not able to do in this analysis, and is just honestly a limitation of research in general, is we can only speak to the impacts for those people who actually receive services. So it's quite true that people of color don't seek out mental health care services for a variety of reasons, including encountering systematic racism in the medical profession and also having inequitable access. So for individuals who aren't able to access them, we cannot estimate what the impact could have potentially been in this evaluation. However, we can speak very candidly about that reality and what we think that disconnect might be. Next slide. All right, and then we had this last bucket, which was more around capacity issues, workforce capacity. We are able to take into account variations in healthcare infrastructure in a number of different ways in our methodology. It is a riddle, but it's a riddle that we feel like we have been able to address so far with our methods. We won't be able to speak directly to the extent of workforce capacity within each of the grantees. However, I do want to point out that currently UC Davis and UCLA are working on a formative evaluation that will unpack some of the questions around workforce capacity more. Next slide. All right, I'm going to quickly update. So who do we have data for and what does that look like? We have a total of 30 grantees for this round of triage funding. That's 15 grantees that service adult and transition age youth, 11 who specifically focus on children, and then 4 school county collaboratives. Next slide. So those counties, this is a slide of the counties that have submitted data to date and who we are working with to provide summaries of the data that they've given us. So we are currently working with these counties to get them information back as quickly as we can and to build the databases to do our larger analysis. Now these counties, large and small, all across the state, servicing a wide variety of individuals and offering a wide variety of programs. Next slide. Okay, lastly, we have now triage data for 16,876 clients. That's about 12,000 adult clients and a little bit less than 5,000 children clients. Now we've received 3 types of data so far that we've asked for. One are just general demographics on clients. Who are people serving? And then 2, encounter data. What services are they coming in for? How often are they experiencing services from this triage program? And then a diagnosis data. We have the majority of demographics data in for both adult and children. The more than half for adults and children for encounter data, and about half for diagnosis data for adults and children. We only have 4 school county collaboratives. We have 2 of their 2 counties have reported, or 2 county school collaboratives have reported data to us. So we have about half of the data from those. Moving forward, where we are now is taking these data to build a larger data set so we can answer some of the most important questions that service providers and counties have for us. So we can get back quickly to them, who they're serving, what does that look like, so that they can drive improvement in their own organizations and with their own partners. We hope by the next time that I see you that I can give you a more detailed and in-depth look at what some of these data sets look like. Right now, we are still in the process of cleaning them and matching them, but we do have them, and that is a very big step in the right direction. And that is where we are currently. That's the state of the triage. We have done a lot since September. We have a lot more to do on our plate. And I look forward to being able to come back with some really interesting and hopefully really motivating data for everyone, both our partners in the county and for all of our stakeholders. Thank you.
Thank you for that, Callie. Let me open it up for questions from committee members. Questions or comments? Yes, Gustavo.
Yes, thank you. Wonderful presentation. I have a question in the, I think it's the slide with having to do with under equity, the demographic characteristics. It's just out of curiosity, oftentimes, I guess, how do you desegregate the various ethnicities or backgrounds? Because oftentimes, for example, you look at Latinos, there's Latinos from different parts of, either Mexico or Central America, kind of get clumped together as one. Same thing with, look at Asian American, Pacific Islanders population, same thing where we don't differentiate between the different ethnicities. So that's one thing. And then the other thing is just in terms of, I see you have for example, like urbanicity, and I'm wondering if it also captures children or individuals in rural parts of the state. So that's one question. The second question I have is on the last slide in regards to or on the same slide in regards to just capturing the children that are, or individuals that are already getting services. And I guess for me, it's still kind of an issue in the sense that we're still kind of focusing on kids that are already in crisis. And I'm wondering what part, and maybe I think you did mention that are we capturing, the prevention, early intervention parts where where the early identification of children or youth, and before they get to services, if that's something that it's somewhere along your evaluation design.
Thank you so much. Those are actually really thoughtful questions, and I'm happy to answer them. So the questions regarding to heterogeneity within race and ethnicity, it's a very important question. Because as we know, experiences can differ vastly depending upon a number of things. One of them just being your origins, how long you have been associated with a given community, your language that you speak. So we don't, of course, we're looking at broad racial and ethnic categories, but by no means is that the extent to which we're looking at understanding the heterogeneity there. So we do have some very important variables that we ask for. One of them is we ask for people's place of birth, their country of birth, and we ask some questions regarding their primary language. And so that allows us to be a little bit more granular. It's, obviously it's not as granular as being able to get the type of, anecdotal, being able to speak with somebody and hear their life story, but it does allow us to look at systematically, are there groups of individuals within race and ethnicity who are experiencing the impacts of triage services or a disconnect in access to them differently, right? And so we don't want to just take a broad stroke of race and ethnicity. We do plan to be as granular as we can. And again, the two ways that we're looking at that, in addition to race and ethnic categories, is looking at country of origin and language.
Thank you, Callie. I see an additional.
I forgot the second part. I'm so sorry of your question. I got so excited about the first part. The second part was simply about looking at age of intervention. So we are able to look at somebody's service history before they experience triage. So we anticipate having a number of years of data before somebody has a triage encounter. And so therefore, we should be able to ask them these questions as if somebody experiences triage services earlier in their trajectory, does that have a different impact than somebody who's had a sustained and longer history of previous services?
Thank you, Callie. I see Kate has her hand up.
Hi, everyone. I'm sorry, I'm going to keep my video off because my bandwidth is low. So if I understand you correctly, Callie, what you're doing is you're really evaluating the programs that got the triage funding. And I'm wondering if there is any attempt to look at really whether this infusion of funding has impacted crisis services at the population level rather than at the program level.
Yes, so actually, this evaluation will take a two-pronged approach because fundamentally, what is the question, right? So are we evaluating, because counties had this wide breadth of ability to implement programs to directly address the needs of the individuals in their community, they're often doing different things with different populations. And so this is a twofold evaluation. First, we will look statewide at, does this additional infusion of funds, have we seen a positive impact from this additional infusion of funds called triage grants? And then the second one will be then to unpack that further. And
how
then,
will you do that?
okay, so we are using we're using some type of analysis that's going to compare individuals who receive triage funds to comparable individuals who did not receive triage funds. And then we will look at a number of outcomes, including
I'm sorry, I'm going to interrupt you. Where is the data coming for that? Like when you say you look at people who didn't get triage, what data are you collecting that will?
So we're collecting behavioral health data, we're collecting education data, we're collecting employment data. We are working with a number of state agencies. So this isn't just coming from the county data. So we're working with a number of state agencies to link data sets so that we can have a much deeper understanding of what's going on for our individuals who are seeking out crisis services. So not all of those individuals are going to encounter a service provider who received triage grants. So some of those individuals are going to encounter services with an agency that did not receive triage grants. And so what we want to look at is, did individuals who actually received services from one of these agencies or one of these providers who had triage service grants, did those individuals have a different outcome than individuals who didn't? And so, but we do obviously there's a lot technically that goes into that. And so that's what this evaluation plan has been about. So currently we have a draft of the evaluation plan already available, and we have the final plan, which incorporates all the feedback that we've received, that is also going to be available, in addition to a high-level overview document, and then step-by-step the feedback that we've received and how we've addressed those. So all in all, the evaluation plan itself is fairly lengthy, and it does go into very detailed questions about how do you identify these individuals, how do you match them up. Just briefly, we're using a number of methodologies with that.
I did not see that provided in our advance packet.
So there should have been a high-level overview and
yeah, I'm looking at it. I'm looking at what I think it is. I think bottom line is I have a concern about your ability I don't understand where you're getting the data for the people who are not the statewide data or the countywide data, the population level data. I don't understand where that's coming from. And I don't understand how you're going to be able to use it to do your matching analyses. So that may be in the evaluation plan that you have. I just haven't seen it. And I don't see it here in what was provided. So I'm just making that comment.
Okay, most certainly.
Thank you, Kate, for that. Kelly, I think that this would be a great conversation to continue offline, because we can both provide Kate and others the detailed evaluation plan and receive the feedback and critiques on, where there are areas of opportunities, where the methodology may not answer the questions. I think we also have to be clear about the levels of questions that we're asking. We clearly care about at the program level, the service provision, impact outcomes at an individual level. But we also have this higher order question about, gosh, this infusion of funds was made available to generate a grant program, a variety of different types of grants which were disseminated. What's our hypotheses about what the measures of success were? How would we know if that infusion, if those grants actually were effective? And do we have the ability to answer, that question if we were to design a new grant program, or to replicate or disseminate programs within individual grants? How would we choose which ones to do? So I think those are questions that we can bring back to discuss. I think we're out of time on this one, and we actually overran our break. I do want to give everybody a chance to break, to have a bio break. And so we're going to take 5 minutes right now and reconvene at 2:15. Callie, thank you very much. Welcome to the commission. Thank you for your presentation and for your openness to the important questions and feedback that this has received. When we come back at 2:15, we are going to pick up on our conversation about metrics, hearing from our presenters from the Children Now program. So with that, see you at 2:15 sharp. Okay, it is 2:15, so I'm going to call us back to order. I know that was fast. Apologies to those of you who are still returning from the break, but I will go ahead and move us forward. Hope that those of you that are still breaking will be able to join on soon. So for our next agenda item, I am going to introduce our next presenters. First, Lashon Francis, who's the director of the behavioral health at Children Now. Prior to Children Now, Lashon was an associate director at the California Medical Association, CMA. She also spent 2 years with the Legislative Analyst Office, where she provided fiscal and policy analyses to the state legislature on issues of mental health, developmental disabilities, and programs for substance use disorders. Lashon and Fatima Clark are going to be talking about California's mental health system and the need for robust, comprehensive metrics. Fatima Clark is the Associate Director of Health of the Children's Movement Equity Fellowship. Ms. Clark joined Children Now in 2013 to spearhead the Covered Till 26 campaign. This was a statewide outreach and enrollment project focusing on promoting Medi-Cal coverage up to age 26 for current and former foster youth. So we invited them here today because they're the authors of the Children Now report that's in your meeting packet. It's entitled Robust Data Systems Needed for California Child Behavioral Health. This report examines the current data and metrics that are collected in California on children's mental health and substance use. The report identifies major gaps that must be closed if California is to successfully make progress and achieve goals to improve outcomes for children and youth. So this could not be more relevant and timely and important, particularly given the large investments that are now being made or poised to be made on children, youth, and schools in California. It also has implications for the Commission's work that we look forward to discussing after the presentation. So with that, let me turn it over to Lashon and Fatima. And you might be muted, can't hear you, but I see you setting up your screen.
Yes, sorry. Thank you so much for having us today. So my name is Fatima Clark, and thank you for that introduction. And we're really happy to be with you all here today. Lashon and I are going to co-present the findings from our recent report looking at data in California. And so I will hand it over to Lashon in a bit, and I will kick us right off. So just for folks who might not know or be familiar with Children Now, we are a statewide research, policy development, and advocacy organization committed to promoting children's health, education, and well-being in California through a whole child approach. So we focus on health and well-being, economic and family supports, child welfare, education, and all with the aim of breaking down silos and really promoting policies that promote optimal outcomes for kids. We also lead the Children's Movement of California, which is a network of more than 4,600 diverse organizations from across the state. That includes child-serving organizations, businesses, providers, and so it's meant to be a network that really comes together when there's collective action that's really needed to move the needle on kids' issues. And so if anyone's interested, we welcome you to join the Children's Movement of California or learn more about the movement. But the reason we're here today is to sort of talk about the report and sort of why we decided to map out all the different systems that we see that publicly report information on children's mental health and substance use issues. And given the intersectional work of our team, we realized that really there are countless measures that focus on children's mental health and substance use available through various agencies. And we really wanted to map that out in a centralized way and identify gaps and recommend ways California can improve data collection efforts to really understand how we're moving the needle on better outcomes for kids and youth in our state, and also make recommendations, which my colleague will go over the findings and how that fits in the current context of all the different initiatives underway in the state. But that was really the impetus, is that we, as a whole child agency, we see these metrics popping up in different places, and we really just wanted to get a handle on what's available and make that also available to the public and to other individuals who might be interested in getting a sense of what data is out there and what are some of the gaps. So our methodology in undertaking this analysis was that we looked at publicly reported data. Our goal was to focus on state agencies, but also perhaps universities or other institutions that work with state agencies, have partnerships with state agencies to assess individuals who access mental health and substance use services. So on the screen, you can see that that entails the Department of Healthcare Services, the Department of Education, CDSS, but as well as UCLA's efforts with the California Health Interview Survey and UC Berkeley's work with the Child Welfare Indicators Project. I would note that we limited our analysis or scan to sources that provided data within the past 3 years. So some data may be available that provides information about the mental health and substance use needs or trends for children and youth, but wouldn't be included in our analysis because either the data was too old or wasn't readily available. Granted, COVID impacted some of that in our analysis. There might have been analyses that were set to be published in the last few years, but due to COVID, there were obviously shifts. One example of that is the Maternal, Infant, and Health Survey. MIHA data provides information about substance use and mental health needs in the prenatal and postpartum period for pregnant individuals in our state, but the data was fell outside of the 3-year sort of window that we set for our analysis. So our findings were that across various different agencies, there were roughly 80 metrics that met sort of our criteria of analysis. And we grouped those 80 metrics into 2 distinct buckets: population indicators that tell us what the characteristics of the child population are in terms of behavioral health, and then system performance, how the child or the youth is accessing care and how it's actually functioning. Within that, we further stratified our metrics into different domains around known prevalence, systems use, how are they accessing services, what outcomes have we seen in terms of children and youth who are accessing services, early identification. So you can see on the screen that those 80 metrics really fell into different, some fell into multiple domains, so it wasn't just system use specific, but it really maybe straddled system use and early identification. And so you'll see that the summary of numbers of measures doesn't total 80, because some measures actually fell within more than one domain and more than one grouping. But by and large, there are a lot of measures that are focused on early identification and systems use, and within just the general domain of population and indicators, but system performance is where we really saw a gap in terms of publicly available data and what we could glean from currently available sources in terms of how the system is functioning for children and youth. So I just wanted to take a quick minute to provide a demo of one second, I have to just pull up the table of the actual platform that we created for individuals, organizations to use. So on the screen, I hope you can see, this is our table that is searchable, and folks can filter indicators based on so you would add a condition, and you can filter it by domain. You can also filter it by focus measure area, organization, the latest time that that data is available, whether race and ethnicity information is reported. And we're hoping that this database allows individuals to really stratify information the way that they like. So if you wanted to understand, let's say, what the Department of Education reports in terms of children and youth mental health and substance use measures, you would select that as the source. And in this case, on the drop-down menu, you would look at the California Healthy Kids Survey. And you can then see the different measures that fall within that specific source. And it could be early identification. You could also filter this table by the actual domain. So if you would like to see what information is available based for early identification measures, then you would play around with the table in that way. And our hope is that this allows individuals to see what information is available from different state agencies, and how in some cases the information is siloed. DHCS might report information on timely access to services, but there's no connection or narrative then that relates to sort of the Department of Education information that's collected around children and youth who need mental health services and how they're accessing those services, or the California Health Interview Survey, which also has measures related to how individuals and young adults access services, whether it's online or whether they've sought care and have not been able to access it. So you can kind of start to see that there are limitations, and even though all this information is publicly available and serves a purpose, it's hard to really understand and parse it together to get a comprehensive view of how the whole system is functioning for children and youth and what outcomes we're seeing with children and youth. And I will just take a moment to bring our slides back up so that I can hand it over to my colleague, Lashon.
Thanks so much, Fatima. I always forget how much work went into creating that Airtable and how much we thought about the methodology. So I hope for everyone that was really clear and concise. And after I'm done, you can see if you have any questions for either one of us. But I think what we wanted to focus on is essentially what we found. And the reality is what we found is very similar to what was talked about during this entire meeting: significant gaps in disaggregated demographic data. I will add, though, that while everyone always talks about race and ethnicity and how important that is, we completely agree. The other thing that was missing, though, was data by age. So we didn't know a lot about the 0 to 5 population, for example, or the transitional age youth population. So your 16 to 21, 25 age group. And those things are really important because we know that they have different developmental needs than, say, our school age population. So that was something that we also flagged in the report. Another thing was lack of data on non-clinical settings. So what's happening at home? What's happening in the community? What's happening in schools? We don't really know about how those interventions are working or not working, or where people are finding support. So we know that there are a lot of services. We know that folks, are funding certain things at CBOs, but we're not really clear on what that looks like, where folks are going, and how much of an impact that's having on their mental health. And then, of course, there's no consistent data across delivery systems. So we found a lot of Medi-Cal data. We can talk about the quality of that data at another time, but there was a lot of it, and there was very, very little commercial insurance data. And we're not really sure when we got to the place where we simply stopped asking questions of our commercial plans. But I think everyone knows that in California, especially, just because you're not on Medi-Cal doesn't mean that you aren't solidly part of a working class or really on the cusp of poverty. And so we really should care what's happening with families who can't afford to pay out of pocket for mental health services. Next slide. So I think there's some opportunities. We all talked about them here today. The Children Youth Behavioral Health Initiative was mentioned. I think someone else mentioned CalAIM. I do want to flag the Cradle to Career data system that is mostly been getting a lot of attention on the education side, and it's going to be a long-term project, but we've described it in our report if you want more information about what the Cradle to Career system is going to look like. But I do think that, you know, $10 million into a data system is interesting, and that folks should be talking about it more and asking questions about what that's going to look like, because the plan there is to integrate data across systems and across sectors. The Children Youth Behavioral Health Initiative doesn't actually have a data component. There's nothing in there that specifically funds data or, you know, funds the opportunity to collect data. And I think that is a missing piece of the initiative. But the Cradle to Career data system is specifically aimed towards making sure that we can tell a particular story when it comes to understanding how children are doing. Next slide. So I talked a little bit about the lack of data and what's missing. I will also say that it is really shameful that we had virtually no consumer experiences and satisfaction data to really point to. And I'm not sure we can say confidently that our mental health system is working if we're not hearing from clients, if we're not hearing from consumers that it's actually working. Same thing for quality, right? We saw very little measures focused on quality and focused on outcomes. We saw a lot of process measures. Was a screening performed? Yes or no? Was medication, was a follow-up plan created? Yes or no? But we didn't really see a lot of things focused towards what this means for how children interact with society. So what we'd like to see, next slide, just so I don't get ahead of myself, Fatima. All right, so what we'd like to see is a little bit more thoughtfulness on what outcomes there might be, right? So we would love to know the percent of children suspended who have mental health or substance use needs, right? That would be a clear outcome to tell us what's working and what's not working. Or the percent of young children, 0 to 5 population, suspended or expelled from childcare programs. That's also an outcome, right? We want that number to be as low as possible. Or the number of school days missed due to a mental health related issue. We want that number to be as low as possible, right? These are things that maybe at some point we might have reported on them, but there isn't a systemic or systematic way to continue reporting on them from the state's perspective. We also want to really investigate the consumer experience. How many parents are satisfied with the type of services that they've received for their child? How many youth are satisfied with the frequency and type of services they've received, right? Who's dissatisfied with their provider or with their services? Who's satisfied? You know, we talk a lot about penetration data because yes, it is so important, and we need to know a little bit more about that gap between who's getting services and who wants services. And that's the missing piece, in our opinion, about what's happening here with access. And I think that is the crux of it. I'll leave this slide up a little bit and see if there are any questions.
Thank you, Lashon. Is that the, oh, I see a hand raised from Sergio.
And Fatima, maybe we'll stop sharing for now since folks have the report.
Yeah, thank you for providing this overview of the work that you are doing and for providing the report itself. I have actually several things come to mind. One of them is, what is the definition of children and youth? What is the age range that you are looking into? And another one is, did you look, for other databases? For example, the CDC Behavioral Risk Factor Surveillance System that collects data on 400,000 people yearly since 1984. And there is a robust number from California. Have you taken a look at that as well? They have been providing for years data, for example, on suicidality, suicidal thoughts and behaviors for kids. Yeah, well, youth. And that's how we know, that adolescent Latinas tend to have greater numbers in terms of suicidal behaviors, for example. So have you taken a look at that?
We're very familiar with the CDC data. I will say that we focused on what the state is publicly reporting for a few reasons. The first being, we do think it's a statewide responsibility to collect data on the California kids population. So that was the first reason. And what we realized too is California needs to figure out what measures are most important to them. And maybe that does include some of what the CDC is reporting on, but maybe that doesn't. Maybe we need to tweak it or add more measures. We have a very diverse population compared to some other states. So in a lot of ways, sometimes those questions might not really get at all that we want to see, but we do have suicidality data. DPH reports on it regularly. That is included in our report as well. So that is California specific to your example of suicidality. I'll let Fatima kind of add something as well.
On the age range, so children now thinks of children and youth as 0 to age 26, because when we think about transition age youth, we really have to still be pretty attentive to the unique needs in life transitions during that point in time. And so we did scan 0 to 26, and to the extent that that breakout was available, we did try and include it. Obviously, that's not always sometimes available. It's just 18 and over as adults, and that's it. And so we didn't always necessarily include those measures because it doesn't actually tell us about the TAY specific population. It tells us about broad ranges of adult age groupings, but not transition age youth specifically.
Yeah, two very quick questions. Thank you for the answers. I appreciate it. One is, there has been other attempts here in California to figure out what are the, measures and the metrics for children and youth, and where those are housed. So, and we have known for years that there are problems, having a unified system, that the different agencies talk to each other, and that, that we have the best possible, more timely, comprehensive, a finger on the pulse of how things are moving with children and youth. I haven't read your report, but do you have you ascertained, some of the barriers for a unified, system of measurement that is comprehensive and that is timely?
Yeah, we did talk about barriers to why some of this data has been hard to collect. I will say, though, it's one of the reasons why we pointed out or included the Cradle to Career data system that's being created as an opportunity, as a potential opportunity, because their goal is cross-sector data. Their goal is to share information across health systems, education systems, child welfare systems, et cetera. It's a new effort by the state, so obviously I don't know how well it's going to go, but they did put $10 million in it in 2021, 2022. So we are watching what they're doing, but that is the goal of that data system.
Yeah, one last question, which is, you mentioned that the time frame for looking is the last 3 years. 2 of those 3 years is the pandemic, and it has had a tremendous negative impact on children and youth mental health. Can you tell us a little bit more about, what is specifically related to the pandemic have you been able to, in terms of the impact on youth, children and youth mental health?
Yeah, so I think that it's a great question. I think that the thing that's become obvious to us is that the state didn't start collecting new type of data due to the pandemic, right? So I think that is one, glaring recommendation or flaw in how the state is proceeding at the moment, is that there are no new metrics that they're collecting that is unique to COVID. all of the data that we collected, they are essentially still collecting as business as usual. Sometimes they might have put a pause to it since the pandemic, but by and large, I don't remember the exact dates, Fatima, but it's not the last 3 years from 2022. I think it's the last 3 years from 2021, because we wrote this last year. So I think that is the biggest thing, is that the metrics didn't really change due to the pandemic, and you can make the argument that they should have.
Well, thank you so much.
No problem.
Bob has a question.
Yeah, I really enjoyed the presentation, and I took a glance at your report. And I have a couple of questions that really relate to the commission and the staff of the commission. One, did you use the report that this group developed to identify the data sources? It's the first comprehensive report I've seen of the data sources involving kids' mental health in different areas. So did you use it? Was it useful? Did you find other sources of data about the kids that you discovered independent of this report? Does this report make it possible to tell you whether you can evaluate triage or not? There are all questions about data. If these data aren't available, what can you ask about triage and what you can ask about triage? Whether the population data, the perception data, or whatever you outcome data, whatever you want to look at. And then I thought that the commission should start from that. The Children's Now group listed on the website is an advocacy group. So we're not. So one of the really important questions, since we've spent most of our time in these meetings talking about inadequate data, would be to look at these recommendations made by this advocacy group about children and evaluate which of them really are useful for doing, correcting, and how long it would take and how much money. So that 3 years from now, we're still not talking about that we have no data to answer the important questions that we want to answer. I mean, it would seem like all of this would be an extraordinarily useful product, especially if California is moving in this direction. But I really thank you for putting together that set of tables. I've looked at them and I'm impressed by the amount of work that you've done to understand where we are with kids. And it would be fascinating to take your recommendations and have this commission begin to say, what really ought to be done, what's the cost, what ought to be done, and if we really want to evaluate the important questions about kids' mental health on a population level and do it with equity, it would be just fascinating to do that now that you've done all the hard work of identifying all the data sources. Thank you for your effort.
Thank you, Bob. I think you perfectly articulated the reasons that we put this on the agenda. And I see, staff nodding, to your comments. I think in the discussion that follows, I think we hope to really surface these questions about, what's feasible to measure based on what we have in this report.
Can I say something really quickly, though, before you move on? I want to just not say, Bob, thank you so much. I will say that when we were doing this and we were looking at the metrics, my favorite metrics actually came from the OAC. And I think the OAC is actually the only ones evaluating their current programs. No one else is really evaluating their current programs, like how FSP works for folks. I think that's an important question. I think obviously the problem is it's limited to the MHSA and it's not truly widespread. So it's not really all kids, right? But that's not a fault of the OAC, right? That's just a function of how the program runs. But I would love if schools were evaluating themselves on how well they were doing with some of their own programming. So I think as you evaluate that question for yourselves, really know that we saw some really positive things in the data that you're reporting, and you'll see that we included a lot of the OAC metrics in our report.
Thank you, Lashon. Kate, I see that your hand is up.
For 1 second. Can I respond to that for 1 second?
Go ahead.
I agree that you could have given the presentation, not as, on what you found that was positive about this. What stunned me was the amount of information and positive people. And it's not clear to me that any of them talk to each other about what they're collecting, but it could be, but you really uncovered an enormous amount of effort that's been done to look at this problem, and you could have presented it positively as opposed to what's missing. What I'm interested in is, can this commission write something that will produce an actionable item from your report that would not be labeled as advocacy by people that don't want to do it, but be labeled as an independent commission activity that would say, here is an outline of what really at a specific level needs to be done if we're going to understand how the mental health of children, improves or doesn't improve over the next decade. That's, I think there's a marvelous opportunity there of the synergy here that we ought not to miss. I'm just saying that. I would put this at a higher priority than doing an inadequate evaluation of a program because you have lack of data to answer the questions that you really want to answer in terms of what's going on, even if that's a statutory requirement.
Thank you. That's a compelling call to action. Kate, I see your hand up. We invited actually both Kate Watkins and Dr. Lynn Toole to specifically add thoughts to this presentation and lead our discussion. And so let me just make a couple introductory comments before I turn it over to you, Kate. Just letting folks know we have a bunch of experts on the subject, but why we specifically asked each of you to lead the discussion. Dr. Watkins is the author of a RAND report that also did a lot of work identifying and proposing frameworks to evaluate MHSA prevention and early intervention programs. And this report included a section on data development and a list of data sources for measuring the 7 negative outcomes. It's been several years since this report was written and published, but it's still very relevant in terms of the content that it has. Dr. Toole, apologies if I'm mispronouncing your name, you can correct me once you come on, but has experience as a child mental health provider and an administrator of a treatment center for children, and is a previous policy advocate for the California Alliance for Child and Family Services. So wanted to invite each of them to lead the discussion. And Kate, let me start with you.
Okay, thanks so much, Itai. So I really agree. I think this is a fantastic report and it's going to be incredibly useful. I have a couple of suggestions for perhaps making it even more useful. One is, I really agree with Dr. Aguilar-Gaxiola about the importance of looking outside the California system, because one of the main designs that you're going to want to look at is this difference in difference design. And that depends on getting data from places that didn't get an infusion of cash. And that's what you have if you use something like the, was it the BRFS, the CDC data source. So you might be able to use that data. You've got the same questions and you'll be able to compare what happened in California to say what happened in Nevada using exactly the same question. So that's really the basis for your difference in difference design. And I think that this data set, which is terrific, could be made even more useful if you add in those data sources. So that's one thing, is I would not limit yourself to just the sort of publicly available California data sets. I think you'll miss a lot of really important and useful data. The second thing is, I think the next step, and this is something that maybe the commission can do, is to start to map these data sources to the evaluation questions so you have this great data, you can now say, okay, for example, suicidality. Here's where I have information about suicidality. We know that one of the aims of the act was to reduce the incidence of suicide. So can we create a logic model that goes from funding to programs to staffing and sort of implementation of programs to actually what happens to kids? And I think what you're going to find is that and then map your data onto that logic model. So you can see which pieces you might be able to answer. I think there's actually a lot we can answer using the data. And so I agree with not seeing see this as a glass half full or 3/4 full, rather than as, oh, we're missing all this stuff. You actually have a lot, but I think you're going to need to try to map it onto a logic model and onto sort of what evaluation questions can this data now answer, now that you know what the data exists. So those are my thoughts. Great job. And I look forward to hearing more.
Thank you, Kate. That's very, very helpful and constructive. Dr. Toole.
Hi, and thank you everyone for inviting me. I used to be a member of the evaluation committee, so it's nice to be back interacting with you all. I'm gonna really focus on 3 different areas for my response. And the first one's gonna take us a little step backwards to really talk about the 5 overarching reminders for good, effective evaluations, which I'm sure you all know because there's a lot of really skilled evaluators here, so I'll be preaching to the choir. The next is a brief response to the report, but also getting more into details, some elements that I think should be tracked, some specific elements that often get forgotten when we're talking about children and families. And then I'll wrap it up with my final comments about recommendations for short and long-term recommendations for your committee and where to go from here. So starting with that, Toby in his discussion did mention that one priority he has, or the OAC has, is educating the elected of all things about behavioral health. So that's kind of my paraphrase of it, not his exact words. But you can't really provide quality information unless you have good data that's giving you that information. So that's meaning recommendations to elected, recommendations to parents on how to serve their youth. All stakeholders need good quality data to be able to be informed on how to change things for themselves and for the systems. So my 5 basic reminders for quality education evaluations, and just to stop, I teach evaluation of public funded programs at University of San Francisco to masters in public administration and nonprofit leaders. So, so this is what I will remind my students they can't leave my class without. The first one is to integrate key stakeholders into every component of your evaluation. So they're the individuals who are recipients of the services, is your most important key stakeholders. If that, in this case, is the youth or their family members or their community leaders that are their significant adult supports. It's also the direct service providers, not just limiting it to the administration of the service sectors, but those who are actually out there every day with the youth and know what they're struggling about. So make sure that they're involved in developing the evaluation studies. The evaluation study, which is hard to do in government work, but the evaluation design has to be developed prior to launching the project. I was really struck with some of the comments in the meeting minutes that you just approved, really discussing that need for, and one of the comments was a preset agreed upon evaluation questions and what the measures will be. When I respond to federal grants, there's a certain percentage that is required of the funding that you receive to be dedicated towards evaluation. So when I'm responding to that proposal, I'm equally evaluated on the quality of my evaluation study as I am the quality of the program I'm put together. So having that in a piece is essential. To be meaningful to multiple stakeholders, you want to focus on measuring outcomes related to what you want to see. What are the positive outcomes? And again, going back in your meeting minutes from last one, there was really a lot of good talk and about, especially member Lyons Newman, her statement that really captured my attention was the evaluation presented previously are mostly focused on the absence of things like hospitalizations and things like that. But what's the replacement behavior for that for individuals like me who are behaviorally grounded? As mentioned before in part of the discussion, there is a tool that's out there that is mandated by both Department of Healthcare Services for especially mental health services for youth and also for Department of Social Services. That is the Child and Adolescent Needs and Strengths two systems are already mandating the same tool. So why aren't we having other service sections also mandate that tool so that we're all looking at the same type of data and we're all speaking the same language? That tool has a lot of strengths, not just for the youth, but for the family. So you can see, yes, decrease in behaviors and symptoms, but also increase in resiliency factors, community support, connection to their culture, things like that. The other important factor I want to recommend to you and also to remember when you do evaluations is start with what you can control. A lot of what you talked about is there's not data here, there's not data there, and you can just, it's crazy making. You can get so frustrated if you focus on that. But there are data out there that you can collect and report on. And you have a lot of control over the programs that you fund and accept proposals for. So that would be a great starting point. In the priorities that the evaluation division strategic portfolio had, their number 5 was evaluating new initiatives for accelerating learning, adaptation, and scaling, which is a great place to start because, again, you have control over those initiatives that you're launching. Also, my reminder is when you're measuring things like equity, don't confuse equal with equity. Giving everyone the same thing, it could be the furthest distance away from equity that you want. Just because something works in one community and one population doesn't mean it could work in another and could actually harm things. So then I'll go to my second section, which is really response to the point, to the report. I agree with Children Now. They have really quality stuff and I love the work you do. And I also agree with Catherine and her remarks before that she made before. But there's also data sources that we're missing from the report. I do think, as Catherine said, going to some national studies, CDC studies and others would be really important in grounding. But there's also some privately funding evaluation studies in the state, like kids data through Lucille Packard and things like that, which get information that public resources really can't get because of their connections with the individuals. You also have something that has stalled at Department of Healthcare Services, the performance outcome system, which is designed to look at the qualitative measures. And that's where we kind of got stuck because we couldn't get agreement on what those qualitative measures were going to be. There was a mention about satisfaction survey, and I agree, we have to focus on what individuals and their family members are saying. That should be our priority, is really hear from them. But I'm very concerned about how satisfaction member information is currently gathered. We ask individuals to fill out a form. The only people who are going to fill out the form are the ones that are going to treatment. So if you're disengaged because you're very dissatisfied with treatment, you're not going to be around to fill out that form. And you have a lot of cultures where they would never say anything negative about their service provider. And so they're not going to be honest if you do get them to fill out that form. So we have to find a better way, maybe focus groups run by community cultural leaders rather than government entities would be really helpful. So what should we measure? We should really take a holistic view of what is important to youth and families, right? It's not just, as a psychologist, I really don't care, which seems strange for a psychologist. I really don't care if someone's depression scale improved 1 standard deviation. I care if they're out of bed, if they're going to school, if they're interacting more with their family. And so we need to move away from those medical model scales and go into, again, what the families think is important. So just a few things that I think are missed quite often when we talked about kids in school, especially with all this money going to school-based mental health. We need to make sure we're touching those kids who aren't in school because of their behavioral health needs, most likely. So we got to find a way to connect with the education system and the department that is in charge of independent study. I've had so many families tell me their school put their child on independent study because of their behaviors. They just told them, your kid obviously can't handle a full day school, so let's put them on independent study. That's the worst thing you can do because they don't have that social interaction and they lose track and they wouldn't be eligible for the school-based mental health service. Same with kids who disappear. Even before COVID, kids disappeared from the school district. No one knows where they are. How are those kids going to get school-based mental health service when the school doesn't even know they exist? So the schools need to find in their evaluation plan, when funding is released, how are they going to identify and engage those youth in those two main categories? The other concern that needs to be addressed when we're addressing school-based mental health is what happens to kids during breaks. So summer break, Christmas break, or where do they go? I've had so many friends that are therapists that have gone to the school district to be a therapist because they're on an academic calendar. So they're not seeing kids during the breaks. Those kids need that continuity of care. Also schools generally, I used to be a special ed teacher and school psychologist, so we couldn't go into the homes. School-based or community-based goes beyond school-based. So we need to make sure that they're actually where the children are. Also similar for the funding that's going to colleges and universities, youth with the biggest mental health needs don't get into those programs. So how is the college and university reaching out to students and helping them have the supports they need to be able to enroll in their college or university? What happens if through the therapeutic relationship, it's decided that that youth really needs to take a break from academics because of their mental health needs? Do they lose their therapist? Those things need to be measured and addressed. And then wrapping up because of time, let me give you some recommendations. So some of my shorter term ones, in addition to what I've already mentioned, is again, developing the evaluation strategy before the RFP is released. So make sure you as an evaluation committee is intimately involved with staff as they develop RFPs. Look to what the funding source had in their reason for why they're funding you. So if you look at a policy bill, all the policy bill fact sheets will tell you what the problem is they're trying to fix with the policy. That gives you a good indication on what you should measure if that policy goes through. Did it accomplish it and meet that problem that was identified in putting that through? Again, start with what you can control. And as you can add other components, you can do that. But the short term is really starting with what you can control as the OAC. And the other really unique one I put in, because I know the OAC has done a lot of work with county mental health boards, is to find out from them, what do they actually hear about children and youth mental health? Are they empowered to get the information and then act on the information? So even doing a survey of their involvement and control or responsibility over the actual mental health services would be helpful. My long-term are data integration. So again, this this outcome system or this cradle to grave data system that's being established, I think is really, really important to be involved in that. We mentioned a lot of data we want to see, isn't there? So start now in helping to identify sources of that data. So 3 to 5 years ago from now, we're not saying we can't get this data. Work with the other entities. I know it's frustration. It's really frustrating to know that DHCS isn't giving you information or CDE isn't giving you information. But find out what their barriers are and help them as their partner at the state overcome that barriers. You guys are too small and have too little funding to be able to take it all on. So partnering with them to help them get their needs met to give better data would be really helpful. And then the longer term one is what's the measure of overall improvement of the system? It would be some indication that the community overall is improving. So look at some of that ACEs data. If we get more services in place, is the community healthier? The community in which the child and family are living, and not just the youth themselves. And then my caution and my frustration as a sometimes grant writer you gotta keep your, whatever data you have to keep it updated. You gotta keep it on your website. Because if someone goes there and it's not there, they're not going to come back to you to look for the data. So consistently post the data. And so in closing, with all due respect, please remember that obtaining and reporting good data is not about you guys as committee members. It's about the youth and family we serve. And so they need to be forefront in all the work we do in developing evaluations and reporting on data. So with that, I'll close and be available to questions.
Thank you, Len. Thank you, Kate, for that. Again, immensely helpful and constructive. And a lot of convergence around some high level, really not even success factors, but just essential critical factors. And we have to become very effective at asking clear questions whose answers are going to be impactful, at having a logic model that underpins how we ask those questions, at mapping data sources to these evaluation questions, as Kate pointed out, as ensuring that stakeholders are involved at every stage of the process. Most of all, Lynn, as you point out, those that we would like to receive services or that don't receive services. So I think that is essential. And I want to turn things over to you, because I know you've been thinking about how does the commission leverage this work to be impactful in the evaluations that we do. So let me turn things over to you with respect to next steps in this discussion.
Thank you. I'll introduce myself. So I'm Anna Nathy. I'm the consulting psychologist for the commission. And I'm going to facilitate the next part of our discussion. We have two questions that we wanted to start with. And they're pretty wide open questions, some of which we've hinted at already. So if we're ready to get the first question up and going. So the first question it's sort of a two-part question, but again, this is something that we've talked about already. So if we were to prioritize community indicators of well-being, where would we start? How would we identify which community indicators are most important for children and youth? The second part of this question is, and then what can the commission actually do? What can the commission measure? So we want to think about just what we've been talking about. How can we create a framework or a strategy to measure children and youth, to indicators of children and youth behavioral health in the state of California? And with that, I'll open the discussion up to committee members. Any committee members that would like to start, please raise your hand and we'll go from there. I realize that's a wide open question. So.
Let me interpret it. It's part of how I hear that question is where to start, right? What to prioritize, given all of the opportunities, right? All the data set, like what's our process for determining what to focus on?
Right. Very, very simply put, how do we know how kids are doing in California? How do in the behavioral health system and just in general, and where should we prioritize those indicators in measuring, given all of the information that we've heard today, all the data sets available? We want to begin to put together a framework to collect this data and share it, and to drive some data-driven decision making. And thinking about, how can we, what data would be important for us to know in prioritizing other things like policy and financial incentives and some of those other things that we have at our disposal.
Well, and one notion that has been raised before, and is whether that focus should be or should it not be initiatives that come through the MHSA. initiatives, because there's so much that the commission doesn't have control over. Perhaps those initiatives are the place to start, and specifically initiatives that come through the MHSA that that address school-age youth. Yeah, Maury.
Wide open question. Thank you for asking that. I think that's why we're all sitting here thinking about it. But I want to respond as a direct clinical provider, somebody who's in an office sitting with an individual receiving services through Medi-Cal, funded through DMH, funded through MHSA. And I think that it's so individual. Every care plan really has some sort of assessment about basic functioning in life. And you're either going from 7 days a week to some sort of 0 days a week or 1 or 2 times a week. But really, the intervention is really about, can this young person survive and do things that is expected developmentally in their place in life? So if I'm working with a developmental disabilities individual, then that metric is going to be a little bit different than somebody who's neurotypical. So, but it really boils down to what the individual sees as a success and wellness versus what I think is success and wellness. And if I come from a community-based model of care and a very, sensitive to the needs of the individual, then my metric for success is going to be their metric for success. And so if the patient and the parent decide that their anxiety and panic attacks are 3 days a week instead of 7 days a week, and that's a sign of success, then that is my sign of success. It may not be your sign of success. I certainly still wouldn't want to be anxious and have panic attacks 3 times a week myself. But if that individual sees that as a success, then I need to go with that. So I think that's why the question is kind of a stump, but it is really about functioning in life. And how does the individual see their ability to function in life? Now, if it's a younger person, it's going to be the parent's view of that. But certainly I work with adolescents and young adults, and I can tell you that my teen or my young adults' view of their success in life is going to probably be different than their parents' view of what they want their young person to be. So my job and our job as clinicians is to navigate the different desires between the two. Now, I will say that the CAND is a good metric. It's a simple pencil and paper metric. So I agree with Lynn, who talked about that as a metric, and we have to do it if that's one way to measure the thing that I'm just talking about.
Thank you. I heard you talking about, valuing the patient, the client's perspective and the family's perspective, and really focusing on functioning rather than some other more clinical indicators.
Right, and it needs to be culturally relevant, and it needs to be taken to all of those pieces that are really important to the family and the individual.
Thank you. Catherine, I see your hand raised.
So I'm going to provide a different perspective, because while I think that is the goal of treatment and of the individual, the clinician working with the patient, I don't know that is workable when you're thinking about evaluation on a large scale, which is what this committee is doing. And so as I think about evaluation on a large scale, I think about outcomes such as how many days missed from school, something that's going to be applicable to every single child. Are they involved in the juvenile justice system? What's going on with foster care? Are they in foster care, out of foster care? Those kinds of things. So while I don't disagree with Maury that you want to individualize the goals of treatment when you're working as a provider with a child, adolescent, or family. I don't think that that kind of outcome is usable or workable in a large scale evaluation. So I would encourage you to pick things that are common, like days missed from school, things like that, or homelessness, or suicidal thoughts, something that every single child can report on or family can report on.
Great, thank you. Sergio.
Yes, thank you. It's an important question, very, very general question. And you're talking about asking about domains. And within domains, you know, it makes me think about the taxonomy of domains, indicators, measures, or metrics, those kind of things. There is I want to, you know, bring to your attention that the National Academies of Sciences, Engineering, Medicine, they released a report in 2019 called Vibrant and Healthy Kids, Aligning Science, Practice, and Policy. And they focus on advancing health equity. I would strongly recommend that you take a look at it if you haven't seen it, because it really identifies key domains for the development, the healthy development of kids. And there is another framework that I have found very helpful. It has taken a lot of you know, attention and traction lately, and that is the vital, what is it called? The vital signs, and just to those are vital indicators, and just to share with you, and I had it here open just to share it with you. If you look at the you know, vital indicators, you will find it in the website. Let me just take a look at what I was looking for to share it with you, and I will send you, by the way, information about those two frameworks. There is a document that is very, very helpful about recommendations for long-term recovery and resilience for social, behavioral, and community health. And in this one, there is also, that was released by the federal, you know, by the CDC specifically, that also have domains of indicators for the healthy development of children and youth. And things like, you know, basic health and related needs, housing, transportation, schooling, you know, and a bunch of other, there are like 7 specific domains that they had focus on. So I would strongly recommend that you take a look at those resources.
Wonderful, thank you so much. And that's the kind of thing that we're thinking of, you know, is how to organize all of this and develop a strategy that would be thoughtful, given all of the data that's available. Committee member Bob, I see your hand raised.
Yeah, I'm going to suggest a different tact here, because I believe that you have to focus really hard And my understanding of children's mental health right now on a population level is that we have a rapidly changing world. And in that world, children have suffered enormous amounts of post-traumatic stress syndrome. And we have effective strategies for dealing with it that can be effective in all different cultures, improve equity in the best sense of that word, and make a huge difference in population health. And the outcome variable to use is grade achievement, or whatever an educator would say ought to be done. I believe that if we lose all these kids because they are so stressed out, the problems that you're going to have in treatment 10 years from now are going to overwhelm the mental health system in California. Now, I'll give you one example from a different field. Years ago, we did a random sample of kids in the San Francisco school system. And we asked a very simple question: could you see the blackboard? And we found that 40% of kids from where they were seated in the class couldn't see the blackboard. And we were wondering about, the teachers were bad, the resources were bad, they needed glasses. And doing the simplest thing to fix the kids with glasses made a huge difference. I think we now know enough from some of the randomized trials that have been done about how to really approach this problem. We need to go to scale in California. The governor needs to understand this, and we need to do everything possible to reduce the stress, whether it's been COVID, whether it's been the opioids, with the crime rate, the prison rate, and the outcome measure we ought to focus on, which we have, because the school system collects it all the time, is performance. Now, if you don't like it because it's culturally biased, then find something you like better. But the bottom line is that you can't, will make no difference if we are all over the place. And by the way, I understand the seriously ill children and adults, and I understand all that, just like I understood the question of how you deal with AIDS and prevent it, or giving condoms, or treat people with HIV. You need some money to help do that. But what I would try to make as my goal is to say we'll be the first state to reduce by 2/3 the amount of post-traumatic stress in kids. If we could do that, everyone in this room would celebrate with champagne and become alcoholic overnight. And I think we actually can do it. I really do. I believe you can do it within a few years. So that's my suggestion to you.
Thank you. I see a couple comments from others, but we are focusing on committee member discussion now. Are there any other committee members that wanted to respond to this first question? If not, we'll move to the second question, and public comment will be at 3:30. Let's go ahead and put the second question up. It's fairly similar, so we can continue. So the second question is, what are the biggest near-term opportunities for the Commission to improve public access to and understanding of key children and youth behavioral outcomes? And should outcomes be defined by specific subpopulations? So for example, taking a look at kids in special ed, or involvement in the child welfare system, juvenile justice, those sorts of things. So part of the discussion, and I think this is where we were hoping we would go to, is, are there models outside of mental health, for instance, in physical health care that we could look toward, that could help us develop some near-term opportunities, near-term strategies for data-driven decision-making. We were also curious how best to use the data that's available. So this question really is more about outcomes. Do we have any committee member responses here?
Well, and I think that the prior comments were definitely really pertinent to this. These are deeply interrelated, and I think the feedback we're hearing is sort of yes and yes. We do need to focus.
Great, thank
on
you.
subpopulation and initiative.
Yeah. Okay, well, Commissioner Danovich, I'll hand it back to you if there's no more comments from the committee members.
You have a comment from Bridget Leary.
I have my actual hand up because I couldn't find the fake hand.
There you are.
Thank you. I just think it's probably worth expanding when we talk about foster care. That's a shrinking population by design, thankfully. At least an order of magnitude, probably 2 orders of magnitude more children are exposed to the child welfare system, are confirmed for maltreatment. And so those that actually make it all the way down into foster care is a relatively small subset. So I think that to expand it to considering maltreated children would be maybe a more appropriate bucket.
Thank you, Bridget. We're almost at 3:30, and if there aren't any other committee member comments, let's move to public comment. Our members of the public have been incredibly patient, and I can't wait to hear their input and feedback on this. So thank you, Lashon, Fatima, thank you, Kate and Lynn, thank you, Anna, for leading that discussion, and thank you everybody for the feedback. I think we have a lot of actionable next steps. But great, I see a bunch of hands up. Kai, can you lead the public comment?
Yes, would be happy to. Looks like we have 4 hands raised. We will start with Teresa Comstock. Teresa, you may speak. Thank you.
Thank you. Hi, Teresa Comstock. I'm the Executive Director for California Association of Local Behavioral Health Boards and Commissions. And we have an issue brief that identifies suggested data points for children and youth for performance outcome data. It's on our website at calbhbc.org/performance. And the suggested data points, were reviewed by our governing board members who are people with lived experience of mental illness, people that are family members, people that are community members in large, medium, and small, and very small counties around California who are on boards and commissions that advise for mental health. The 3 areas for suggested data points, and before I go into these 3 areas, I should say data should include outcomes specific to culture, race, ethnicity, and age. But the 3 areas that were identified and suggested to be tracked would be school-based wellness. That would include attendance, grades, and classroom behavior. Secondly, standardized screening and assessment. And then 3rd, reporting by self and family. Thanks.
Thank you so much, Teresa. Next, we have phone number ending 1718. You may now speak. You can.
There, I unmuted myself, sorry. This is Steve Leone, client and advocate of many years. I served on this committee in all prior iterations. So it's like coming home a little bit. I wanted to say, first of all, the importance of qualitative approaches. I want to echo what Toby said at the very beginning of the meeting. You know, qualitative strategies, including focus groups and key person interviews, et cetera, and not limited to that, certainly. I also wanted to say, Lynn Thule, that I also served with for a while on the Thule committee. I support everything she was saying and her outlook as well. And I think you should really listen to her and use her. I wanted to make another comment, however. It's interesting, as we progressed along, there was a woman, I think it was Marie, who said, you know, that as a therapist, you know, the person I'm serving, their metric, you know, like, becomes my metric. And that outlines the relationship she has with that person. And somehow we have to find a way to track, in a broad sense, how prevalent such constructive and open relationships are with people, because it can make a critical difference. A program that is of the same kind, quote unquote, might fail in one place and not fail in another. And it's that relationship that makes the difference. And I further wanted to make the point that this was followed up by, there was a critique from one of the other members of the committee that said this is not scalable, it's not doable, as outcomes, that are so varied. And I want to make the point that, in fact, if you think about it, Marie's, the therapist's local outcome working with the person actually represents a style of interaction with someone. It represents a process metric. And you can then measure outcomes however you wish, on the broader scale. But unless the program incorporates the right kind of process, you may not see as much success as you would like. Thank you.
Thank you, Steve. Next, we have Laurel Ben-Hamida. Laurel.
And also, sorry, Kai, to jump in, but Martin had raised his hand earlier in the session. I want to make sure that we get him too.
Was that an invite for me? You can go ahead and have everybody else. I appreciate it. Am I on?
Yeah, Martin, yes, you had raised your hand a lot earlier. I think it just got.
I have been in therapy and everything since I was a kid, actually. My mom and my parents had sent me to therapy. I've been having trouble accessing care since I've been back in San Bernardino. I've gone to the county services. I've gone to Inland Psych for the second time. And basically, I can't get a doctor to actually have a discussion with me about the actual truth of what is called gang stalking. I am a targeted individual of gang stalking, and I've been a targeted individual for 16 years. And this is now researched on the National Institutes of Health. There are 3 separate research findings. And the first one that appeared is as of April 2020, which is a doctor's repositioning of what has been the narrative that we are all suffering from a mass delusion. And I need to have a mental health care system take and address that there are thousands of people, if not tens of thousands or hundreds of thousands of people, that are targeted individuals of gang stalking. And I need to have a resource to actually at the cusp of this, and the Mental Health Accountability Office needs to take a consideration of a grant or funding or something to bring us all into a focus and put a stop and into this. On February 2nd, appeared before the city council meeting here in San Bernardino on a person who was a targeted individual with gang stalking. This is a narrative that needs to be brought forward, and I'm at my last wits to try to get a doctor to actually bring forward the truth. That's all I have to say. My name is James Martin Driscoll. You can Google me. My last name is spelled Driskill. And I have an address to the Accountability Office on Facebook and everything. So I've been trying to connect on social media. So I'm out there as an advocate, an activist on this particular topic. And that's all I have to say. If anybody has anything to say to me, that'd be great.
Thank you, James. I don't have an immediate response, but I appreciate you being here and I appreciate sharing your concerns and your experience.
Thank you.
Okay, next, thank you, Laurel, for your patience. You may speak now. Thank you.
Thank you. I'm Laurel Ben-Hamida, and I am a volunteer at Muslim American Society Social Services Foundation in Sacramento and in California, and on the board of REMCO. I wanted to ask for an update at a future meeting sooner rather than later on the threshold language data collection, analysis, and waiting period. I'd like to know, and I think we all need to know, how the needs of newly arrived Afghan refugees, so many of whom are children, probably by far the majority are children, are going to be addressed in light of the following problem. Afghan is not a language. Afghan people speak mainly two languages, Farsi Dari, so Farsi Persian you may have heard of. Dari is the Afghan one of the Afghan official languages. They're very closely related, partly mutually intelligible. And another language, Pashto. Now, if data for Afghans are divided into, by numbers, into Farsi Dari speaker data and Pashto speaker data, it will take much, much longer, maybe years longer, for Afghan newcomers, mostly children, as I said, to receive the benefits of being speakers of threshold languages in the counties where they are residing. They are almost all, I think we could agree, without exaggerating, at risk of PTSD, adults and children. Delaying prevention and early intervention perks of being a speaker of a threshold language to many Afghans, and treatment as well for those who already have PTSD, will be a sad commentary on our system. So I would like I think this is the committee that, along with the Cultural and Linguistic Committee, the CLCC, the two committees that might best meet and find out exactly how the threshold language issue with regard to the newcomer Afghans is being addressed.
Thank you so much for your comments, Laurel. Next up, we have Steve McNally. Steve, you may speak.
Thank you very much. I appreciate that. I'm Steve McNally. I'm in Orange County. I'm on a behavioral health advisory board, one of the local boards that Lynn spoke of. None of my comments will be reflective of that particular board. They'll all be my own personal comments. I love coming to these meetings and some others around the state where I can learn a lot of stuff. And so I want to reinforce a couple of things. One is I want to amplify Lynn's comment about trying to get the local boards involved. We are 59 boards. We are over 900 people. Some really engaged, some not, but we are 900 people, including 59 electeds. And as a family member, and if I have to hear one more public hearing where a state agency says, we don't think we can't collect the data because we don't feel we're empowered to do it, I'm going to throw up. So I'm going to also ask that you consider us to be a funding mechanism for what you're trying to accomplish, and find county carve-outs within existing data. So if there's a data source in the state that my county could pay for to get county level data, I would love to know how to do that. And you've heard me before, as some of the commissioners, that if we can spend up to 5% of MHSA on community planning, which to me means awareness, research. It's a crime that in year 17, we don't know capacity, we don't know what works. I can only hope that CalAIM doesn't follow suit. That's $100 million collectively, over 7 million in my county. It's over almost 20 million in LA County. If you put LA, Riverside, Orange County, San Bernardino together, which represents 45% of California, America's 5th largest state, it's a lot of money if you could help focus us. And the other thing is, people were talking about older data sets. And I liked what Robert said, because I'd heard that thing from couldn't see the blackboard for some people with fund eyeglasses. There's tons of research available in the archives of the OAC. You just got to, and I see Teresa there, I owe her the document because I pulled it out. When California still cared about data, back in the 2012s and 13s and stuff, you can see all the codes identified WIC codes identifying certain data, where it's pulled from and who pulls it. And all of a sudden, all that institutional knowledge, like what happens a lot of corporations, people move jobs, or you had somebody who really cared about a certain job and made it really great. Institutional knowledge gets lost. And so I would just ask, before we create a lot of new stuff, is that we make sure we use what little we currently have. And I do like the Cradle to Grave. I've been to their presentations. And I also like the open data portal. Not too many people talk about how to make that raw data that's in these open data portals and make it usable for counties to use the decision making, because the counties aren't going to do it on their own. And I shouldn't say they won't, because some counties will, but for the most part, they're just not motivated. You know, that was pre-COVID. And with COVID, when LA, at an LA Mental Health Commission, LA staff says 31% open positions currently at COVID. I'm not sure what the rest of the counties are looking at, but when they had fully staffed, they weren't that excited about data. And when they're at this level, possibly MOUs across counties might be possible with managed healthcare, Medi-Cal, everyone, because we're going to have a real need to do it. So thanks for letting me say my piece. I'm going to be making myself president of the fan clubs for the lady presenters today, at least this one, the children's stuff, because I always like them anyway, and then the other two discussers. So you have a fan club in 92627, and I've appointed myself president of it. So thank you, ladies, and you guys have a great day.
Thank you, Steve. Our last public comment is Hannah Bickoff. Hannah, I apologize if I mispronounced your name. You may speak.
Thank you so much. Actually, you got it perfectly right. So thanks again. My name is Hannah Bickoff, Policy Director at Cal Voices. Really thrilled to be part of the discussion and learn so much today from the great presenters. I just have 3 quick points that just sort of stuck out to me throughout the meeting. I wanted to thank Dr. Ewing for his sort of overview of the current projects and data analyses going on at the MHS-OAC. I think it's really helpful for stakeholders and consumers to understand sort of the lay of the land. And at our organization, Cal Voices, we're very interested in sort of the ways in which counties are using their funds. And one thing we came across recently was that the fiscal transparency tool does not show unspent funds from 2018 moving forward. So I think that that information, having that data readily available, would be really helpful to kind of help track sort of how counties are using their money. And as we know, that's sort of how these systems, where they start and how we see services and different sort of programs form. And then I wanted to also thank all the presenters on the Children's Now report, a very fascinating and well done report. I just want to reiterate a specific comment made by Dr. Thole around strengths-based metrics. I think one thing that really stood out to our team is that the measures are largely deficit-based in terms of, and apologies, I think my internet's going out, but they're largely deficits of where our system's failing youth and families, and it would be really helpful to look at more recovery strengths-based areas of where individuals are growing and excelling within the mental health and social service systems. And then the last measure that we wanted to bring forth that I don't think has been discussed a lot today, but we see pretty frequently among our consumers and stakeholders is IEPs as sort of a signal of how youth and families are doing within the school systems. As many of you know, children and families have a hard time accessing IEPs and then utilizing them in a way that's really useful to their mental health or whatever sort of disability or challenge they're struggling with. So I think the ways in which we can focus more attention on who's getting IEPs, how they're being utilized, and what the outcomes are is really, really critical, especially as we watch youth navigate the virtual to in-person to virtual to in-person school system. So just wanted to uplift those few points, and thank you again for the discussion today.
Thank you, Hannah. Commissioner Danovich, it looks like we have a last minute hand raised. Do you want to take that? Okay. Elia Gallardo, you are next.
Thank you very much. Just a quick comment, and thank you for taking me at the last minute. We too are very interested in the information. I'm Elia Gallardo with the County Behavioral Health Directors Association. We've historically used the Transparency Suite data in order to show and demonstrate some of the work and activity that's happening, and are one of the, I would consider to be one of the primary users. Have had lots of conversations with the data team, and they've been very, very effective and very, very productive. One of the main things that we've been concerned about and continue to be concerned about, and the OAC has always been very responsive, is to make sure that the information is presented as accurately as possible and in a manner that gives a clear understanding of how the Mental Health Service Act works. The Mental Health Service Act is the way that it's funded is funds are encumbered over a 3-year plan period. It's done in collaboration with the community, who has to approve those plans along with the Board of Supervisors. Those plans run through the boards and the commissions at the local level. And we just want to make sure that when information is presented, that the audience, who may not be as familiar with the MHSA as the audience that's currently on the line, clearly understand how MHSA runs, how it's done, and how funds are encumbered in the program. Thank you.
Thank you so much, Elia. Commissioner Danovich, this ends our public comment period.
Great, thank you, Kai, and thank you for all the comments. And it's particularly pleasing to hear that the transparency suites are viewed as valuable and are being utilized. A ton of work went into building them, and so it's good to hear that they're being put to use. Steve, I want to invite you, no pressure, but to make any comments or observations that you might want to make regarding today's meeting.
Thanks, Itai. Actually, I would just like to say that everything discussed today was really interesting and helpful in different ways for the commission from my viewpoint. But in particular, the report on the data to me is foundational to our efforts to improve outcomes for for everybody that accesses the system. And I believe that a shared data is just critically important to understanding where the gaps are and where the opportunities are to improve. And so I personally plan to get more involved and understand how we can move the importance of data forward at a commission level. So thank you for that.
Great, thank you, Steve. And to our commission staff, Kai, Anna, Toby, we understand that there are mandated reports and then our discretionary and foundational reports, Toby, as you described. I think one of the feedbacks, the overarching themes from the committee is that we have an opportunity to have an impact by selecting an area or a limited set of areas and asking some very focused questions that we think are going to have an impact, preferably around an area that touches the work of the commission and in our subpopulation of school age youth. So I think we have some work to do in terms of incorporating the reports that have already been put together, articulating with some of the questions, the logic models that underpin them, determining what's feasible based on existing data sets, and where we can answer some impactful questions. I think that's our next step. I think we need to come back to the committee with some proposals, and then have the committee help us pick apart what's wrong with those proposals or why we should be asking a different question before we launch into them. But that's what I take as our call to action, and that will and admittedly that's going to be something that may be difficult to do while we are replacing the director of the division who's so instrumental to that. But I think we can't wait because these issues are critical, and I think this is a doable call to action, even with the transition of that role. That's how I heard it. Any comments on that? Anybody hear that different? And or does the staff have any questions or comments about what's come out of today's meeting? That must be unanimous agreement.
I'm sorry to interrupt, but I was asked a question through the chat and I can't do chat. Just wanted to let Sharon know, yes, that is the right issue brief. Thanks.
Toby, it looked like you were about to say.
Yeah, Commissioner Davies, I just sort of in that context, clearly the committee heard many of the tensions that we're seeing around a kind of population level data and very specific issues around how we measure and report and the impact it has on things like, how whether or not we reflect threshold languages. There's just, layers going on here. The Commission several years ago adopted a regulatory framework to gather data based on, this gets to something that committee member Gustavo Loera raised earlier, where we require tracking based on an expansive range of different race, ethnicity, disability status, language spoken, sexual orientation, gender identity, and so forth. And the law says that subsequent to that, the Department of Healthcare Services is supposed to require regulations that are comparable to the Commission's or substantially similar. And the whole idea is that over time we would get better at data collection. There's a lot of reasons why that's not happening, and a lot of reasons why it would be important to happen. And so we do have some opportunities to sort of dig in on that kind of a very specific issue. But what I really wanted to highlight is, consistent with the example I gave of our fiscal transparency tool, something that the Commission did on its own under its discretionary authority, what we're seeing now is conversations with the legislature, because they're using that there are discussions about actually mandating that reporting and even going above and beyond that. And so some of this is about how we create the opportunity to identify some core metrics that are useful. That process may not be mandatory at the moment, but it could, as a result of doing the work, become something that is directed to happen. There are a couple of legislative proposals moving forward to require the identification of outcome measures. I will point out that there's already statutory requirements for this to happen, not for the Commission to do it, but for the Health and Human Services Agency to do it. And as Lynn Thole said, we've sort of stalled on the performance outcome system under DHCS. And so I just want to, as an aspirational opportunity, say we don't have to boil the ocean and try to do everything that's out there. Dr. Brooks said focus is really important. But if we also think about how that focus could actually result in statutory change and utilization of those data, it really can become an important step in informing decision-making in some programmatic areas, but also informing decision-making about how data gets used in state government, which I think is what Dr. Brooks' core comment was about this editorial, is how do we begin to demonstrate the essential nature of data to support public policy in California. So just, some very optimistic opportunities, some hope in how this work can actually drive transformational change.
Great. Are there any other comments? So seeing none, I think we can go ahead and close the meeting. Thank you all for participating. Thank you for our those that helped to lead our discussions and to make presentations. Thank you to our committee members and staff, and to the members of the public, many of whom bring great content expertise in this, as well as being members of the public, and could just as well serve on this committee. So thank you all, I appreciate it. And we have a lot of work to do. with respect to next steps. So look forward to taking that on. Bye.
Thanks, Itai.
Thank you.
Thank you, everybody. Bye-bye.